Electrophysiological properties of the sinoatrial and atrioventricular nodes. Electrophysiological studies in sinus node dysfunction. Diagnosis of sinus node dysfunction, SND, should rely on non-invasive methods, rather than on electrophysiological studies, EPS, because results of EPS can be normal in the presence of symptoms of sinus node dysfunction and vice versa. The most reliable non-invasive methods are 24-hour Holter monitoring, which may show ECG criteria for sinus node dysfunction, and exercise testing, which may reveal chronotropic incompetence. EPS are indicated in symptomatic patients, mainly with syncope, in whom non-invasive tests could not reveal the cause. Electrophysiological, EP, criteria for SND include the presence of one or more of the following. 1. Abnormal sinus node recovery time test. 2. Prolonged sinoatrial conduction time. 3. Sinus arrest. 4. Sinoatrial block. 5. Sinus node reentrant tachycardia. Sinus node recovery time, SNRT. The calculation of SNRT is used to test the integrity of the automaticity of the sinoatrial node, following overdrive pacing. It is assumed that automaticity recovers less rapidly in diseased than in healthy sinus node. The SNRT is the time interval between the last paced captured beat, to the first spontaneous sinus beat. Other calculated measures include corrected SNRT, CSNRT, and the ratio of SNRT to basic sinus cycle length, CL. CSNRT is calculated as SNRT minus resting CL. This high right atrial, HRA, tracing shows the last four stimuli of atrial pacing, S1, followed by a pause before the reappearance of the first spontaneous sinus A wave. This pause represents the SNRT. The cycle length, CL, after the first spontaneous sinus A wave represents the basic sinus CL. The CSNRT can then be calculated as SNRT minus basic CL. The second sinus A wave was followed by a secondary sinus pause. Abnormal SNRT test, indicating SND, is characterized by any of the following. 1. Prolonged SNRT greater than 1500 millisecond. 2. Prolonged corrected SNRT, CSNRT, greater than 500 millisecond. 3. Increased ratio of SNRT to basic CL greater than 1.6. 4. Secondary sinus pauses, after reappearance of the spontaneous sinus rhythm. Sinoatrial conduction time. The sinoatrial conduction time, SACT, is the conduction time of the sinus impulse, through the sinoatrial junction, to the right atrial tissue. Sinus node reset by an atrial extrastimulus, EASE. When an EASE is fired in the high right atrium, HRA, it enters and resets the sinus node, that is, it stimulates the sinus node ahead of time, earlier than its intrinsic cycle length, then a new spontaneous sinus impulse arises, and conducts out into the HRA. How to measure SACT? The Strauss method is an indirect measurement of the SACT. An atrial extrastimulus, EASE, is fired in the HRA, close to the sinus node, then the SACT is measured as time from the EASE to the next spontaneous sinus beat minus basic sinus CL, and the difference is divided by 2, because the difference represents the conduction in both directions, from HRA to sinus node, then from sinus node back to HRA. This is illustrated in the ladder diagram, showing normal conduction of the first and second sinus beats. AB interval represents the basic CL. ECG shows normal PQRS waves for these beats. EASE is delivered close to the sinus node. It conducts into the sinus node to reach it after a certain time, T, representing the atriosinus conduction time. It also depolarizes the atria with P wave appearing in ECG, and conducts to the ventricles showing QRS complex. Following the basic sinus CL, AB interval, the sinus node fires its next impulse. This impulse conducts to HRA after a certain time representing the sinoatrial conduction time, which is assumed to be equal to the atriosinus conduction time, T, after which the next P wave appears. The CD interval is thus equal to the atrio-sinus conduction time, T, plus the sinus basic CL, AB interval, plus the sinoatrial conduction time, T, i.e. CD equals AB plus 2, T. The sinoatrial conduction time, T, can then be concluded as, T equals, CD minus AB, divided by 2, or time from the ease to the next spontaneous sinus beat minus basic sinus CL divided by 2. Reference range for SACT. In children, 50 to 125 milliseconds. In adults, 200 to 250 milliseconds. Electrophysiological properties of the atrioventricular node. The atrioventricular node, AV node, has characteristic electrophysiological, EP, properties, most notably its decremental conduction, which may exist in other cardiac tissues, such as the sinoatrial junction, much less likely in the His-Purkinje system, and rarely in the bypass tracts. Characteristic AV node properties. Identifying the properties of AV node conduction is essential, to distinguish it from bypass tract conduction. 1. Decremental anterograde atrioventricular, AV, and retrograde ventriculotrial, VA, conduction is generally characteristic of the AV node. It can rarely, however, occur in bypass tracts. 2. Dual AV node physiology occurs in some persons. 3. Concentric VA conduction, concentric retrograde atrial activation, is characteristic of the AV node, while VA conduction in bypass tracts is usually eccentric, unless the tract is very close to the AV node. Study of AV node properties. The EP properties of the AV node can be studied using the following maneuvers. 1. Atrial extrastimulation, EASE. 2. Anterograde atrial burst pacing. 3. Ventricular extrastimulation, VES. 4. Retrograde ventricular burst pacing. Decremental conduction. Decremental conduction means that, stressing the conduction tissue with stimuli, that come earlier and earlier, at progressively shorter coupling intervals or cycle lengths, results in conduction tissue fatigue, with gradual prolongation of its conduction time, the Wenckebach phenomenon, until the tissue is no more able to conduct, an impulse block occurs. Decremental conduction of the AV node is usually demonstrated in EPS as gradual prolongation of the AV node conduction time, that is, the AH interval. Decremental conduction may be demonstrated by either extrastimulation, introducing EASE or VES at progressively shorter coupling intervals, or by incremental atrial or ventricular pacing, pacing at progressively shorter cycle lengths. AV node decremental conduction can thus be demonstrated anterogradely, that is decremental atrioventricular, AV, conduction, or retrogradely, that is decremental ventriculotrial, VA, conduction. Anterograde, AV, decremental conduction. Atrial extrastimulation. Start with atrial burst pacing, usually for 8 beats only, at a fixed CL, typically 600, 500 or 400 milliseconds, to stabilize the CL, then introduce 1, 2 or 3 E's. Atrial extrastimulation is useful to study. 1. AV node refractoriness and conductivity. 2. Dual AV node physiology. 3. Initiation of an arrhythmia. In this study, atrial bust pacing ends at S1, followed by an ease, S2. The HRA channel shows the atrial pacing spikes and the A waves. The HB channel shows the spikes and the AHV waves. The AH interval, AV node conduction time, is obviously longer after S2 than after S1. The shorter coupling interval, CI, before S2, than the pacing cycle length, resulted in more stress to the AV node, prolonging its conduction time, the AH interval. This is a classic example of anterograde, AV, decremental conduction of the AV node. In this case, E's were introduced at progressively shorter coupling intervals, CI, from 1 through 4, and the AH intervals progressively prolonged. Another classic example of anterograde decremental AV node conduction. If the patient has dual AV node physiology, it can be revealed by decreasing the CI of E's 10 millisecond each time. Dual AV node physiology, indicating the presence of dual, fast and slow AV node pathways, is defined in EPS as marked increase, jump, of AH greater than 50 milliseconds, for a 10 millisecond decrease in the CI of the E's. If the CI is further shortened, the E's may be blocked, indicating that it arrived at the AV node during its effective refractory period. In this study, the pacing spike of the E's, S2, is seen followed by A wave, but no H or V waves. This means that the impulse blocked between the RA, A wave, and the His bundle, H wave, obviously in the AV node. After the blocked impulse, sinus rhythm resumes, showing AHV in HB, AV in CS, and V in RVA channel. Atrial pacing. Pace at the high right atrium, HRA, at gradually increasing rates. Look for gradual prolongation of AH interval, decremental conduction. The relationship between the pacing cycle length and the AH interval, AV node conduction time, can be demonstrated in this AV node function curve. The shorter the pacing cycle lengths, the faster the pacing rates, the longer the AH intervals. With further shortening of the pacing CL, AH jump may occur, which is again diagnostic of the presence of dual AV node physiology. Thus, dual AV node physiology can also be defined as AH jump greater than 50 millisecond for a 10 millisecond decrease in the pacing CL. AH jump in patients with dual AV node physiology is explained by conduction block in the fast pathway and shift of conduction to the slow pathway. To conclude, anterograde AV decremental conduction can be demonstrated by 1. Atrial extrastimulation, shortening of the coupling interval, is associated with prolongation of the AH interval, AV node conduction time, that is, slower AV node conduction, until the Wenckebach CL is reached, and the E's is blocked. 2. Atrial, anterograde, pacing, shortening of the pacing CL is associated with prolongation of the AH interval, until the AV node Wenckebach period is reached, and 2 to 1 AV block occurs. In this study, the first beat is conducted, the spike and A wave in HRA channel are followed by V wave in RVA channel. The second beat is blocked, the spike and A wave are not followed by ventricular activation. The process is repeated in a 2 to 1 block pattern. It is of note that 2 to 1 block can be either type 1 or type 2 AV block. In our case, since this block occurs with gradual shortening of the pacing CL, decremental conduction, it should be type 1, Wenckebach, block. The CL at which this occurs is called the Wenckebach cycle length. Ventricular extrastimulation. Start with ventricular pacing for 8 beats at a fixed CL, typically 600, 500 or 400 millisecond, to stabilize the CL. Then introduce 1, 2 or 3 VES. Ventricular stimulation is useful to study 1. AV node refractoriness and conductivity. 2. Dual AV node physiology. 3. Initiation of an arrhythmia. In this study, the HRA channel shows the A waves resulting from retrograde VA conduction of the ventricular pacing to the atria. The ventricular pacing period of 8 beats ends at S1. The second beat, S2, is the VES. The RV channel shows the ventricular pacing spikes followed by the V waves. Shortening of the CI, in the right-sided tracing, is associated with prolongation of the retrograde ventriculotrial, VA, conduction time. This is a classic example of retrograde VA decremental conduction. Further shortening of the CI, may result in VA block, when the ventricular refractory period is reached, again demonstrating the Wenckebach period, but in the retrograde direction. Ventricular pacing. To examine the retrograde VA conduction during incremental ventricular pacing, pace the RVA at gradually increasing rates, and look for decremental VA conduction. Further shortening of the pacing CL, results in Wenckebach VA block, and determines the retrograde Wenckebach CL. Retrograde atrial activation pattern. With normal retrograde conduction in the AV node, During ventricular stimulation, the earliest A waves appear in the His bundle HbECG, followed by radial, concentric, spread of the impulse, first in the atrial septum then in the atrial free walls, almost simultaneously in both atria. Concentric VA conduction, concentric retrograde atrial activation, means that the central, medial, tissue is stimulated before the lateral. This is demonstrated in the coronary sinus CS channels. A waves appear in the proximal, medial, channels, 7 and 8 in this case, before distal, lateral, channels, 1 and 2. Eccentric VA conduction, eccentric retrograde atrial activation, means that the lateral tissue is stimulated before the central. A waves appear in distal, 1 and 2, before proximal, 7 and 8, CS channels. This situation means that conduction is going in a bypass tract, not in the AV node. Retrograde atrial activation with bypass tracts. In the presence of bypass tracts, eccentric retrograde atrial activation occurs, unless the bypass tract is very close to the AV node. Depending on the site of the bypass tract, atrial activation pattern changes. With a right-sided tract, A waves appear in the HRA channel before the CS tracing, left atrial activation. With a left-sided tract, A waves appear in the CS, left atrial, channels before the HRA channel. Thank you.